Good afternoon, everyone. Thank you so much for being here. I do want to disclose that I'm here because of you all, because my neurology colleagues already know what they need to know. They know much more than I do, actually. So disclosures, I don't have any disclosures. I do want to mention that I trained under Dr. Dumulik and Dr. Diaz back in 2022, and I can never thank them enough for the training that I got, because I can proudly say that I'm a neuroimmunologist. Though I don't work at UNC, I work at Raleigh Neurology Associates, but UNC will always be very close to my heart. And then, this is not a publicity stunt, but I can manage to get you in to be treated for high-dose IV steroids the same day. Okay. Now, when you talk about symptomatic management, you heard a lot about the symptoms that occur in all of these three conditions. The antibodies that we have are very, very different in NMOSD and MOGAD-associated disease, or depending on what the etiology of the transverse myelitis is, it may be very different. But, could you definitely consider this as the two sides of the same coin? I think based on symptomatology, probably yes. Symptoms are attributed to inflammation in the brain and spinal cord. Now, one thing that we should focus on is NMOSD, because it does give rise to some disabling symptoms if we compare to MOGAD and transverse myelitis, let's say idiopathic transverse myelitis. First thing is optic nerve inflammation. As you can see on the upper left corner, you have the retina, which is the main area that receives the light impulses. And then afterwards, the signals go backwards into the optic nerve, and then they eventually converge into the visual cortex, which is the main area where the signals are interpreted. So I'm going to talk to you about what the, is there really a pointer? Yes. So I'll talk to you about what are potential optic nerve inflammation symptoms in the next slide, but I want to talk about other symptoms related to the brainstem and area postrema. So when you talk about area postrema, that's a specific location in the midbrain. The midbrain is the middle part of the brain that holds a lot of important structures like the midbrain pons. It has a lot of important cranial nerves that control the function of the body, especially like, eye movements, facial, expression, numbness, sensation, all that stuff. Interestingly, people can also come with intractable hiccups as an initial presentation of NMOSD, which is pretty fascinating, but it's all corresponding to that brainstem area postrema area. There can be unexplained sleep attacks or narcolepsy sometimes, and if you are having other symptoms like numbness, tingling, or vision problems, and you're having sleep attacks, I think you should bring this up to your neurologist and request for an MRI brain, because this may be related to a lesion in the diencephalon, which is this location of the brain in the purple color, which leads to sleep attacks. And of course, there are other components of narcolepsy that a sleep specialist can evaluate you for. You've seen this slide a zillion times now, so I'm going to try and breeze through this as fast as I can. Spinal cord, fascinating organ, leads to so many different nerves that control not only movement, sensation, they control function of a lot of different organs like bowel, bladder, control sexual function, et cetera, We'll go over some of those in detail. Now, talking about optic neuritis, I want to touch on that a little bit because this is a very, very important symptom. It can be an initial manifestation in 30 to 50% of NMOSD patients, and it can be as high as 60 to 80% in MOG-associated disease. And these individuals can actually have optic neuritis during their disease course at any time. So in MOGAD, it could be up to 40 to 60%. In NMOSD, it could be up to 50 and 80%. And as Dr. Graves mentioned, that in NMOSD, the optic neuritis is severe, right? It comes with profound vision loss. It can be bilateral meaning affecting both eyes at the same time, or it can be recurrent, where it can be sequential, meaning one eye affected first and the other eye affected second within a short period of time. In MOGAD, again, it could be both eyes, or it could be one eye and then a recurrence in the same eye. As we know that vision loss is more severe and frequent in NMOSD as compared to other demyelinating conditions, the incidence of visual disability is about 50% at 5 years in NMOSD population. In MOG-associated disease, they have a better long-term visual recovery as compared to aquaporin 4 positive NMOSD. And one thing is, like, although relapses may be more frequent in MOG-associated disease, the fraction of patients that end up with severe visual disability is much lower, like, in the single digits. What are some fascinating visual phenomena that you can see in optic neuritis? One term is called palinopsia, where you will see a shadow tracking the object. Like if you look at this dog on the right side, you can see the shadow that's tracking the dog. I found it very interesting. The other are phosphenes, which are like bright spots you can see in vision, or you can see flashing lights. Now, point to be noted is that sometimes you can have these visual phenomena even before you actually go on to develop like profound vision loss and pain with the optic neuritis. So if you're having some of these symptoms, I think being evaluated by an ophthalmologist is completely reasonable. Acute management, I think everybody talked about this. I think everybody knows now it is high-dose IV steroids. Trust your gut instinct. If you feel like something is going on with your vision, do not wait. Call your primary care physician or call your ophthalmologist if you have one. I recently came across a case where the patient came to me after 7 days of some blurriness in the left eye. Coincidentally, when she woke up, she also had some redness of the left eyelid and a bit of swelling, which her primary care physician diagnosed as a sty, which is like a little bit of an infection, so treated with topical antibiotics. The primary care physician just tried this, warm compresses, and see what happens. However, the second and third day, since her vision continued to get worse, she decided to go to her eye doctor and then eventually came to me. So luckily, she was able to come to me within 7 days of the onset of symptoms, and we arranged for the high-dose steroids in a timely manner because the ophthalmologist clearly saw optic neuritis. The optic neuritis treatment trial is something that we have heard of since the late 1980s, 1990s, early 1990s. Basically, it gives us guidelines in terms of how you treat an acute attack of optic neuritis. These were individuals between ages of 18 to 45-ish, and they presented with optic neuritis within the 7 to 10 day time frame. And what they did was they compared high-dose IV steroids to oral prednisone and then placebo. The bottom line is that with high-dose IV steroids, there's minimal or no impact on the long-term visual outcome. They do say that it may hasten the recovery process, but we also know that it helps to prevent a second attack if you're able to treat with high-dose IV steroids in a timely manner. Now, a question that I actually get is the visual recovery timeline, because if someone comes to me and she's gotten the high-dose IV steroids, and after 2 weeks of getting that, she comes to me and says, well, doc, I don't think that my vision has gotten any better. I try to clarify whether there has been maybe 10 or 20% improvement. At that point, I try to reassure her that this will continue to improve, because there's an initial recovery phase that may last anywhere from 2 weeks to 6 weeks. However, it also is very variable, because if you have someone coming in with profound visual loss in either eye or bilateral visual loss, and you've had treatment with high-dose IV steroids, but with minimal improvement, then there's also a low threshold to treat these patients with plasma exchange sessions. Sometimes At WakeMed Raleigh, what we like to do is alternate high-dose IV steroids with plasma exchange sessions for a dual benefit. It's done on a case-by-case basis, basically. Now, there's an intermediate phase, which is 6 weeks to 6 months, which means that 80% of the patient may regain their most of the vision back, within 6 months. And then there is also a late recovery phase, which means that your vision can continue to improve for up to 1 year, which is interesting. You may have some residual visual deficits, like some color vision impairment or contrast sensitivity, which could just be the residual symptom after 1 year. Now again, as I mentioned, that it also depends on what condition are you dealing with, because I mentioned to you that NMOSD, the optic neuritis is severe and may not recover entirely. It also depends on, what is the age of the patient, how severe the vision loss was at the time of presentation. Could the patient actually visualize your face or hand motion or any finger movements? And then also, how many MRI brain lesions did the patient have? Because if you have a lot of brain MRI lesions, they say that it may also affect the recovery process. When we've done the acute treatment phase, then next is visual rehabilitation, and Dr. Cleveland did an amazing job. The PM&R folks did an amazing job. I think that one thing that I want to add is the visual rehabilitation part. Each state has a commission, and there are low vision clinics that receive that commission, which is good for each state in that regards. If the patient lives in Raleigh, closer to the clinic, I refer them to the Mikowski Visual Learning and Rehabilitation Clinic. She is extremely, I would say, competent and very, very good with her patients, and then communicating back the results to us. I know that UNC and Duke may also have their services as well. Sometimes it's a little bit difficult for the patients to travel to Chapel Hill or Duke for some reason, right? Okay. Another avenue is North Carolina Division of Services for the Blind. They also have a Raleigh district office, and they can also give you more information on independent living. They can do low vision assessments and also provide assistive technology. Now, visual rehabilitation is a very interesting thing. And doing research on this a little bit more, I'm going to share a video with you in a bit. But if someone does have a little bit of permanent visual disability, I would say in NMOSD, then there are some assistive devices that may really help you, function, basically. You can have some talking products. You can have a talking clock. You can have video magnifiers. There are service dogs, right? Everybody wants to keep a dog. That's a question we always have. There are some places that train certain specific dogs. You have electronic canes, which is very interesting. It can kind of tell you where the obstacles are. GPS. This thing on the bottom right is called the script talk. You put the medication bottle on that device and it reads out the prescription aloud in terms of what the medication is, how many milligrams, and how are you meant to take it. Or you could request the pharmacy to provide blister packs. Now, I'm not very tech savvy. I know some people are not. But with advances in technology, you can see like the iPhone and Android apps have Android phones have a lot of really, really good apps, and most of them are actually free. So I wanted to show you this video, if I can play it. I hope so.
Did you know you can use Google Lookout to receive detailed descriptions of images, to read documents, food labels, and much more? Firstly, head to the Google Play Store and download Lookout. Once you open Lookout, you can access the menu by swiping right. Here you can choose a category which best suits your needs. Once you've selected a category, hold up the item in front of your camera.
Dear Tim, thanks for all your help. From Mark.
Lookout is great for reading handwritten letters, food labels,
Walker's crisps ready salted.
and it can even describe images. To do this, head to the Image tab, then press Choose Image. Lookout will now describe the image for you.
Details. Dogs. Pet. Fur.
Guide dogs.
So there are several apps like, Seeing AI, Tap See, Lookout by Google. Those are all, free apps you can try. Blindness resources. Yes, blindness resources. Just, gonna skip this one because I'm sure LaShonda will give you a whole lot of information on that as well. When you talk about lack of mobility, there are different factors which, are responsible for that. Is it muscular weakness? Is it spasticity? Is it chronic pain? Is it fatigue or depression? Most of those, symptoms are the reason why a lot of people probably couldn't attend this conference in person. Pain is something that deserves a lot of attention. Now, nociceptive pain is something that is a physiological response. For instance, if you're cutting a fruit and you cut your finger with a knife, the pain receptors in your muscle or your skin are activated, and then you get this coordinated reflex and a behavioral response saying ouch on that, which is something that's meant to happen, and it warns you about this injury. Now, neuropathic pain, on the other hand, is a little bit different because it is because of injury to the somatosensory pathways. What are somatosensory pathways? Anything affecting the brain, spinal cord, and those nerves. Any kind of inflammation in those areas, injury, stretch injury, etc., will lead to a neuropathic kind of pattern of pain. Now, in NMOSD, MOG-associated disease, and TM, you will see an acute kind of pain related to a relapse or active inflammation. And if these symptoms are lasting for more than 3 months, you call it chronic pain. Now, NMOSD and TM pain has a prevalence of over 80%. And you can have like kind of a mixed pain pattern where you have a combination of neuropathic pain. You can have some pain related to spasticity, contractures, which is just like a fixed posture, and moving those limbs would be very, very painful. In MOG-associated disease, the pain prevalence can also be up to 70% in some case reports. People may have headaches or retroorbital pain, in addition to the other kinds of mixed pain syndromes that I discussed. Now, talking about management, I think Dr. Cleveland did a great job. I do want to mention that it could be a combination of medications. It doesn't necessarily have to be one single nerve pain medication or a muscle relaxer. I think trying everything in a combination makes more sense if you're dealing with different kinds of pains. Traditional medications, as you all know, gabapentin is something that everybody knows about. There are traditional muscle relaxers. I don't want to go into the details of that because you already heard that. There are certain antidepressants that also help with a lot of pain. So if you have concurrent depression, I think those would be a good choice. I always hear from patients in clinic, can you give us something stronger for pain? I think the expectation is maybe narcotics, So to that I say that, there's, not a whole lot of data to support that these opiates benefit, or help treat this kind of neuropathic pain. So for that purpose, I've seen some neurologists prescribing low-dose tramadol. I don't think personally, like when patients come back, they say that it doesn't work. So my preference is not to prescribe that the opiates, but if it's intractable pain, then maybe sending to a pain specialist makes more sense. Another question that I get from some patients is, can I take marijuana? Okay. So
how do you answer?
it doesn't matter what I say because whoever enjoys taking it will continue to take it, right? I think that medical marijuana is legalized in North Carolina just for intractable epilepsy, and that's a specific kind of epilepsy. It's not legalized for any other kinds of conditions. Though a lot of people do come back and say that we kind of feel relaxed and it does help our pain. Is it a psychological, thing? It may be. But when we talk about spasticity, in the mouse models of autoimmune encephalitis, they did find that some of the cannabinoids were able to relieve the spasticity in those mouse models. One thing about the weed part is I think that it has a higher content of THC, and there are long-term side effects, especially cognitive side effects that I do get concerned about. And then, I think that it may be a potential option like the medical marijuana, but, there's no robust data to recommend that kind of. Paroxysmal tonic spasms, I wanted you to see this video. This person has transverse myelitis, and as you can see, the left arm and left leg is going into this painful spasm. So what is a paroxysmal tonic spasm? It is like a little bit of a painful, usually painful, and it's a stereotypical posturing of either extreme. It could be arm, leg, or both legs or both arms. Typical duration is anywhere from a few seconds to less than 2 minutes.
How you doing?
They're more associated with NMOSD than other conditions. I didn't see a whole lot of literature on MOG patients developing these kind of spasms. But when you talk about the etiology of these spasms, there could be related to lesions in the spinal cord. You could have thalamus, or like the brain involvement, thalamus, subthalamus, or internal capsule. Then these lesions are also like present in multiple sclerosis and other demyelinating conditions. So theoretically, it could probably happen to these other conditions as well. And one thing that you see is like there's a dramatic response to a medication called carbamazepine in these patients. What are non-pharmacological therapies? Dr. Cleveland clearly mentioned all of those treatment options, so I think I'm going to skip that, but there are, again, some mindfulness apps like Headspace or Meditainment that you could download, and sometimes it's more like a biofeedback or cognitive behavioral therapy to manage chronic pain. Spasticity, I'm going to skip here. I don't think we need to talk about that at all. Bowel and bladder issues, I'm not sure if that patient is still here. We talked about spastic and flaccid bladder. One important level in the spinal cord is T12. Any kind of inflammation above T12 would lead to a spastic or reflexic bladder, which means that the bladder muscle is very hyperactive, contracting. There's urgency, there's increase in frequency, and any lesion or any inflammation below the T12 level would lead to an areflexic bladder, where there's no tone in the bladder, and there's the bladder starts collecting urine. There's backflow of the urine to the kidneys. She mentioned what to do when you have a spastic or a flaccid bladder. I do want to mention this cool neuromodulation part, which is a posterior tibial nerve stimulation device, and they put the electrode in the posterior tibial nerve, which sends impulses up to your sacral plexus and helps to regulate the movement or contraction of the bladder. It may help with some of the spastic bladder symptoms. When we talk about medications, now, if you look at the table here, the left side, you're seeing some of the traditional medications. These are anticholinergics. Unfortunately, they do come with some intolerable side effects, like more urinary retention, dry eyes, dry mouth, may also cause cognitive impairment if you already have some memory issues. The medications on the right side, I think, are a little bit better tolerated. However, there's sometimes an insurance denial issue. I was able to find Myrbetriq on the Mark Cuban Cost Plus Pharmacy website. So whenever you're looking at any kind of medication that's not cost effective, apart from GoodRx, please do check the Mark Cuban Cost Plus Pharmacy. these medications do not work well on flaccid bladder. So what are your options? You have catheterization, or there are very fascinating surgeries that some institutes are doing. I have to talk to Dr. Borowski about any of the surgeries, whether she does those or not. But at Johns Hopkins, they can, place an external opening in your abdomen and bypass the urethra, which is the bladder outlet. And, from that opening in the abdomen, you just kind of collect all the urine out. Of course, it will require a lot of care and cleaning. You can also do a stent in the urethra and bypass it, like a longer stent that goes directly into the bladder. There are other surgeries like bladder augmentation, where you connect the colon to the bladder to actually support the movement. Neurogenic bowel is the same concept. Any inflammation above T12 level, you'll have a spastic or reflexic bowel, and any inflammation below that level, you'll have a flaccid or areflexic bowel. Basically, the treatment is kind of the same. You have to have a good bowel regimen, high fiber diet, treating constipation, and then what are different minimally invasive. There's an anal irrigation. You can put a catheter inside and irrigate the stool to loosen it up, or you could have surgery, eventual surgery, which is a colostomy bag. If you've heard about that, it's like an external opening and everything is collected inside a bag. I think, me being a neurologist, I think this is kind of new to me as well, because when a patient comes to us with these kinds of complaints, I have a patient, whenever he gets constipated, his left leg goes into a bad spasm, okay? So we tried all kinds of stool softeners, anything that I could think of, but at the end of the day, I'm not a gastroenterologist, so, he's now seeing a gastroenterologist in the hopes that we can find something reasonable for him. They did mention some pelvic floor therapy and biofeedback to help with the constipation issue. I think on the Ask the Doc panel, I mentioned that please make sure you're getting your yearly blood work. Please make sure you're getting ultrasound of the kidney or bladder if needed. Of course, these are things that the urologist will bring up. However, since you need to be your own advocate, it's important that you talk to the urologist as well. Because of the constant irritation of the bladder and colon, you can always have some kind of concern for malignancy. If you're more than 50 years of age, they do recommend screening for prostate cancer. That's a blood test called PSA. Of course, colon cancer is also important. It's important in this, not only in the sense that it could detect malignancy, but again, with those immunosuppressive medications that you will be on, there may be a little bit of a risk of malignancy with some. Sexual dysfunction is a discussion that most neurologists, well, I wouldn't say most, but I think at least 25% of the neurologists do not have with the patient. I think initially the reason I wouldn't bring it up was because I thought maybe I didn't want to cross some boundaries. But then now my approach is that my realization is that, it's very important for mental and physical well-being, right? It's a very important function. So I do wait for the patient to tell me, but if they do not tell me, I do inquire at the end and see what we can do. There can be a primary sexual dysfunction, which means that it is because of the disease process itself. There's inflammation in the brain and spinal cord, but there is a secondary cause as well, which is medications. A lot of these medications that we take for anxiety and depression, even for blood pressure, may cause a bit of sexual dysfunction. Illicit drugs can cause a sexual dysfunction. And now the third thing is a tertiary sexual dysfunction, which means that because of the disease process itself, you are concerned about your performance, you're concerned about your physical disability, and that leads to a low sex drive. Now, medications on the right, I think the one that I may be comfortable prescribing would be the Viagra in select cases. These are phosphodiesterase inhibitors, and they help improve blood flow and maintain the erection. There's no like female Viagra, but there are some other FDA approved, like there's one FDA approved medication in the female, and I'm blanking out on the name, I apologize. There are some off-label medications. Recently, a urologist put one of my patients on Kibergalin, and we'll see what the results are. Because Viagra didn't work for him. Then there are some topical medications as well. I just put this picture in. I kind of like the picture because if you have a supportive partner, I think you're blessed. Sometimes people do come in and they're very emotional, but the spouse would say, he doesn't have MOG, I have MOG as well. We have MOG together. So if you have a supportive partner like that, you should be very, very thankful for your blessings. But if you're having some kind of marital strain because of the sexual dysfunction or any other issues like depression, please seek counseling, marriage counseling, very important. I think I want to skip this one. Skin breakdown, Dr. Cleveland did, describe all of this. I did notice that if you have some kind of redness on your skin and you press on it, and if it doesn't blanch, then it may be the beginning of a pressure ulcer. So you definitely need to establish care with a wound clinic and have regular skin checks. I do get another important question is, what can I eat, right? So what dietary modifications can I make? Usually for skin protection in general, or, healthy well-being, you have to intake a lot of fresh fruits, fresh vegetables, but omega-3 fatty acids, vitamin C, vitamin A, zinc. The question is vitamin D. Why do we stress on having a good vitamin D level? Low levels have been associated with the risk of relapse and disease progression in NMOSD and possibly in MOG-associated disease. We have a lot of data in multiple sclerosis for that. The goal vitamin D level should be more than 40, and supplementation doses depend on what the level is. Depression is another area that I think is very, very, very important to address. And I think one of the fathers was very concerned about the daughter not wanting to get occupational therapy or was just resistant to it. So I think depression screening does make a whole lot of sense in that kind of scenario where, accepting the disease, the diagnosis may take a long, long time. There are patients who come in after several years, and at that point, they're ready to start some kind of maintenance therapy. And when I ask them what caused the delay, they say, well, we didn't accept it. Okay, so depression, if someone's exhibiting any kind of suicidal tendencies, I think it's a medical emergency. You need to take them to the ER, make sure you see a psychologist or psychiatrist. This is in conjunction with medications. There's a high prevalence of depression in NMOSD and MOG-associated disease. As you know, with severe disability comes depression. It is very natural. 21% of NMOSD actually endorse suicidal ideation. More than 50% of the NMOSD patients do not receive appropriate antidepressant medication therapy. Some of them may be a little bit resistant too. That's what I've noticed, like people don't want to be put on medications that would impair their thinking ability or cause some intolerable side effects. In transverse myelitis, the rates are comparable to MS, but again, I think that also depends on what the cause of transverse myelitis is. Let's say, for instance, if it's a cancer-related paraneoplastic transverse myelitis, I feel those patients may be more depressed because of dealing with a separate kind of cancer in addition to the spinal cord inflammation. Traditional medications, first line are SSRIs, sertraline, Prozac, Celexa. I'm sure you've heard the names. I like sertraline a lot. In low doses, it's really good for anxiety management. In high doses, it's also good for depression management. I think I've had only one person come back with some heartburn issues. Otherwise, it's a well-tolerated medication. I think other medications are also excellent. If it's neuropathic pain and depression, you could try a little bit of Cymbalta, duloxetine, or venlafaxine, which is SNRI. When you have sleep issues, you have a bit of depression, then I mentioned to you that tricyclic antidepressants, amitriptyline, nortriptyline would be good. If you have fatigue or sexual side effects, then the safest options for you would be mirtazapine and bupropion. Cognitive impairment, one of the moms asked about that. And I second everything that the expert said. Do want to mention that there may be two areas. One is the corpus callosum, and one is the diencephalon that I mentioned previously in an MOSD. When these areas are affected, then you can definitely have some deficits like, maintaining a good attention, processing speed may be delayed, working memory is affected, you can have executive dysfunction. So in NMOSD, 30 to 70% may have those kinds of issues. In MOGAD, the incidence is a little bit lower. They also did a CogniMog study, and they said that the cognitive function in MOGAD may remain stable over time, but no significant decline observed in follow-up periods. Fatigue is the invisible disability. It is very difficult to quantify. One of the patients said that she was unable to progress in physical therapy, or what could I do differently? I think that, first of all, listening to your body is very, very important. Do not overdo it. Whatever you were able to do before this diagnosis, your functionality was different. Now it's going to be a little bit different. Take it one day at a time. There can be primary fatigue, which is the result of the disease process, but as Dr. Dumovic and Dr. Graves mentioned, secondary fatigue occurs because of various medications, depression, poor sleep, infections, or the fact that you're exerting a lot of effort during ambulation. The key point is to identify the underlying cause of the fatigue. When all else fails, rest is recommended. There is no FDA-approved medication for fatigue management. However, we have used amantadine, modafinil, sometimes Prozac has been used if you have depression, or some of the stimulant medications that we use for ADHD may help some with fatigue. My personal experience with that is I wasn't very keen on prescribing Adderall, but lately I've been doing that, and I have noticed some improvement. I kind of guess that those individuals did also have a component of ADHD that was undiagnosed. You could reorganize your home and office to conserve energy. Now, AI is fascinating. I want you to look at this video that I actually made myself.
Stephanie and her friend were in a restaurant when her friend asked Stephanie what it was really like to live with a long-term health condition. Stephanie grabbed a handful of spoons and handed them to her friend. The spoons each represent one task or one thing that uses up energy. The point is that for people with a disability, there is only a limited number of spoons available to use in one day, and in some days you will have more spoons than on other days, for example after a bad night's sleep. With just one spoon left at the end of the day, Stephanie explained to her friend that if she cooked, she wouldn't have enough energy to wash up. If she went out for dinner, she may be too tired to drive home safely. She has learned to plan her day and always keep a spoon in reserve in case it is needed.
Thank you very much. I wanted to mention disability is a matter of perception. If you can do just one thing well, you're needed by someone. You're all very special to us and the chosen ones. Thank you for giving a purpose to our lives as well.